We'll start this session. We're in Hall B, and if you're not supposed to be here, go now. It's my pleasure to introduce this session and just say a few words. And the first thing I'd like to do is to thank the local organisations for inviting us and putting on a phenomenal conference. We can see that's going to be the case already. I'd like to thank all those people who've come from all over the world to support this conference, both as speakers, chairpersons, attendees, delegates, whatever. And this is a truly international conference, and as far as I'm concerned, the highlight of the year. We have a number of eminent co-chairs. I'm going to ask them to introduce themselves just to say hello in this opening few minutes. But we'll all say a little bit about each other as we introduce them as they speak. And of course, we'll introduce the speakers who are not co-chairs. So if we start at this end, ladies first.
From the University of Exeter.
Good morning, Michael Kawoya from Uganda, Kampala.
Good morning, I am Hanan Guefel from Cairo, Egypt.
Thank you very much. So the first scheduled talk is Karen Knapp, and we have an introduction for Karen. Thank you.
So, Karen Knapp, we are honored to have you as our first speaker. She's an associate professor of MSK Imaging, Musculoskeletal Imaging, at the University of Exeter, and chair of the research committee of European Federation of Radiographers Societies. She's also chair of the Bone Densitometry Training and Accreditation Panel for the Royal Osteoporosis Society. We are looking forward to hearing from you, Karen Knapp.
Good morning. We're just waiting for my talk to come up, and we'll be right with you. Good morning. Assalamu alaikum. Thank you for inviting me to speak at this conference. In this session, I'm going to talk about the justification for imaging in patients presenting with long COVID and what we need to know as radiographers and technologists. These are my disclosures. I'm going to be discussing the background. Long COVID is a new disease for us, and so we're learning as we go. I'm going to talk a bit about the epidemiology, and this is going to be focused on the UK epidemiology because we have good statistics about what's going on. It's also quite a large problem in the UK. I'm going to touch on long COVID symptoms so you know what to look for in your patients. I also think about some of the causes of why the patients are suffering from these symptoms, and then think about the imaging which we might need to use for long COVID patients. So looking at the epidemiology, Long COVID has only been around for about 2.5 years, but it has some similarities to chronic fatigue syndrome. In the UK, we have more than 2 million people noted to suffer with long COVID, and that's about 3% of the UK population. So as you can see, this is actually quite a large problem for us. 807,000 of those people have suffered with long COVID for more than 1 year, and 403,000 have been suffering for 2 or more years. So this is a long-term condition that is affecting people for a long period of time. So what is long COVID? Well, we typically see that patients will have an acute COVID-19 infection, and this may not be a particularly severe infection. It might be mild symptoms at the time, and certainly a lot of our long COVID patients were never hospitalised with COVID-19. After the acute phase has finished, the patients either don't get better or they start to deteriorate again. And in the UK, after people have been suffering with their symptoms for 12 or more weeks, they are diagnosed as having long COVID. But long COVID presents as a multitude of different signs and symptoms, and so there's no formal diagnostic test that we can use for long COVID. It's really a case-finding strategy to identify the symptoms and whether the patients have had a COVID-19 infection. And this in itself can be quite difficult because widespread testing for COVID stopped recently in the UK, and so not all patients will have had a positive COVID-19, and we know when we check for antibodies there are a few patients who really don't have a good antibody response. So the signs of long COVID and symptoms: in about 56% of patients, they will present with fatigue, and this can be really severe fatigue to the point where they struggle to get out of bed or are bedridden. About 31% will present with breathlessness. 28% describe something known as brain fog, and that's where their cognitive abilities are not what they had before COVID, and they struggle to think and struggle to find words as well. 21% will present with myalgia, and this can often be worse in the mornings on rising. And about 15% are coming in with arthralgia, as we know as well. And we know that our rheumatology services have seen an increase in referrals with patients with joint aches, but not all are presented with rheumatoid arthritis. So we know this presentation is impacting on the referrals to multiple services in the healthcare system. There are a number of factors which result in these symptoms. There's clearly inflammatory processes going on, and patients with long COVID tend to have increased inflammatory markers in some cases. Clearly with the brain fog there's some neurological aspects. There's a psychological aspect, but this is primarily talking to patients that the long COVID is causing psychological problems. This is not that long COVID is a psychological disease, and there's a real concern with patients with long COVID that they're being labelled as having a psychological background to their disease. And it has a major impact on their lifestyle as well. So we know that about 375,000 people in the UK who were working before they had long COVID are no longer able to work. So it's a big economic impact as well as for the patients themselves. So the causes for long COVID are really still being investigated, and we're a long way away from finding answers to this. There's a hypothesis that we're having tissue hypoxia, and we know in some patients with long COVID who've had microclot tests done that they are having microclots, and this might be microclots impacting on capillaries and poor diffusion. However, we don't do microclots on everyone. It's a very niche test. There's a hypothesis it might be partly the healing process, and we do know that some patients who've had long COVID for 12 or 4 months do get better on their own. There's also a hypothesis that it may be an autoimmune response, so the immune system has been primed to COVID and it continues overreacting to that acute COVID infection. And one of the main hypotheses, which seems to be building a bigger evidence base, is that there's an ongoing mini-infection caused by a reservoir of virus which the body hasn't been able to tackle. And this has been evidenced by patients with long COVID who on various swabs are still testing positive for fragments or whole parts of the virus itself. So imaging recommendations for long COVID are going to be far-reaching and wide, and actually it's really important for us as radiographers, radiologists and technologists to understand the signs and symptoms and what might be coming our way in the future, because it is a new disease and we don't have set guidelines for imaging in these patients yet. Clearly, patients with pulmonary symptoms need to have investigations, and the symptoms that we get for long COVID are not mutually exclusive from other diseases like early stage cancer, so we need to be ruling out other things. So chest x-rays and CT is going to be key in these patients, and we know that our patients with COVID who are in intensive care, a lot of them have long-term lung damage as well. About 1% of patients with COVID are presenting with ongoing cardiac issues, so we're going to see an uptick in chest CT and MR for patients in this group. Patients do also present with abdominal problems, so CT abdomens can demonstrate inflamed bowel, and we also know that the liver is very key, and we're seeing a lot of inflammation of the liver and pancreas in long COVID patients. Neurologically, again, it's going to be ruling out other factors. And one thing I will say is when you're imaging in long COVID, a lot of your patients are going to come back with negative tests because there's not anatomical changes as a result. So CT brain and MR is going to be ruling out other reasons for this, but we do know on PET-CT that patients with long COVID have reduced brain metabolism, which is potentially accounting for the brain fog. In rheumatology, joint ultrasound is going to be key, looking for inflammatory processes in the joints to understand what treatments are going to be needed. And DEXA may be useful in these patients. We know that if they have reduced mobility, they might have fairly rapid bone loss, and so we need to make sure that we're looking after their bone health. And finally, vascular ultrasound and CTPA or VQ scans are going to be key. We know that there's increased clotting in these patients, and we also know that we see more pulmonary embolisms in them. And the endothelial damage in COVID and long COVID suggests that it's very much a vascular-mediated disease. So long COVID is a growing problem, particularly in countries like the UK, where we've had multiple waves of COVID, and those waves are getting closer together. It's causing problems for our workforce, but it's also causing a large increase in the requirements for imaging and our healthcare service. There are clear physical causes for long COVID, and we're still exploring why these are happening. The imaging required for long COVID is going to be wide and varied in the same way as their symptoms are wide and varied, and a lot of it is going to be ruling out other pathologies. It's likely to lead to an increase in demand in our imaging services to increase long COVID, and we need to be factoring this in the modelling of our service needs for the future. Thank you for listening.
We have time for one question.